Thank you. Respected chairpersons and dear chairperson Dr. Deepthi, distinguished delegates, dear friends, a warm good morning to one and all. And I would set my sincere gratitude to Jagashan sir and the entire advances team for giving me this beautiful opportunity. As we all know that in our day-to-day practice, we are all dealing with ovarian cyst. So most of our patients, they may not prefer an immediate surgery or something like that. So most of them, they prefer a conservative management. So it's our duty to differentiate a benign cyst and a malignant cyst, and definitely, and then only we can offer them a conservative management. Otherwise, it will be very difficult in future. So it's often difficult also to differentiate between a benign cyst and a malignant cyst clinically. So let us today see how to diagnose and differentiate a benign and a malignant ovarian cyst. So approximately 3 lakh new ovarian cancer cases are diagnosed annually worldwide, and among that around 2 lakh deaths is happening per year. So to differentiate between the benign and malignancy is often difficult, and lot of screening methods, lot of criteria, lot of risk assessment criteria methods has set in. And basically, if you want to divide, you can divide it as three parts. That is functional cyst, benign cyst, and a malignant cyst. So that will be easy for the further diagnosis and all. Then borderline tumors are also upcoming nowadays very wide, and borderline tumors usually can be treated with less aggressive techniques. So that is the importance of differentiating a borderline tumor. So what are the risk factors and what are the signs and symptoms? You might be knowing all this, but basically ovarian cyst is part and parcel of infertility treatment. As part of the hormonal treatment, as part of our ovulation induction regimes, we often come across with ovarian cyst during the follicular monitoring and all. And during pregnancy also, you might be seeing follicular cyst or a corpus luteal cyst. Then chocolate cyst is part and parcel of endometriosis. And most often, most cases, the severe pelvic infections, if the lady has severe PID or something like that, she can go in for an abscess formation or cyst formations. And we often have seen ladies, unfortunately, with the recurrent cyst formations also. Especially in postmenopausal ovaries, we have seen persistent recurrent cyst and all. So basically, the signs and symptoms you might be knowing, most of the cases will be asymptomatic. But they might have a dragging pain or a light pain in the abdomen like that. But there are certain warning signs. Of course, you might be knowing that. So when the lady is having any heavy irregular bleeding, polymenorias, and unexplained bleeding, discharges and all, then dyspareunia, difficulty while passing motion, then blotting sensations, early satiety, and all those things, you have to be more cautious, especially the feeling of mass abdomen, feeling of abdominal distension, and all those things. So how can you assess the risk? So basically, the tumor marker carries an important role. Next comes the risk malignancy index RMI 1, 2, and 3, 4. Then human epidermis protein 4, HE4, that's another tumor marker. Then Roma index, I'll be going through these risk criteria soon. Then IOTA symbol rules and 3-step strategy. The symbol rules risk calculation method and ADNEX model. And of course, ORAD's ultrasound model. So just coming to the basic investigations, you have ultrasound is a gold standard for the ovarian cyst. So if you are doing the ultrasound, it's well and good, but you have to be very careful. You have to have an idea about the ultrasound features very well. Or if somebody else is doing, you can just go through the pictures and have an idea, can make your own concept about the type of cyst. So ultrasound is a basic thing and the best thing to diagnose an ovarian cyst. Then you of course have to go ahead with complete blood count, then CRP to rule out infections and all, and inflammations. Then if you are suspecting a complex ovarian cyst, especially in a premenopausal lady and all, and as well as in adolescents, you can definitely go ahead with the other tumor markers like LDH, alpha-fetoprotein, HCG and all. And LDH will be elevated in dysgerminomas, alpha-fetoprotein in yolk sac tumors, then HCG and all basically in germ cell tumors. Then CA125, another important marker. Then CA125 will be elevated in epithelial ovarian tumors. Then if you are suspecting any, clinically if you are suspecting any signs of precocious puberty, a proper hormonal profile has to be performed. Then among these, HE4 is the most specific one. So HE4 is human epidermis protein 4. It is neither organ specific, neither tumor specific. Then it is overexpressed in ovarian tumors, so its specificity is around almost 95%. And another important aspect with HE4 is that it is not affected by the endometriosis. And hence it is more specific, especially in premenopausal women. So next about the most common tumor marker CA125. Most of us are left and right doing it, and most of the times patients will be often confused seeing the cutoff values and all of CA125. So you have to properly counsel them. And they might have a feeling that it is malignancy and all, and after the googling and all. So CA125 is usually elevated in 80% of the epithelial ovarian tumors and not in mucinous tumors. So cutoff is, of course, you might be knowing that it's 35 international units per ml, and it has a sensitivity of around 81% and specificity is only 75% because it is raised in so many other conditions. So even in non-malignant conditions like inflammatory disease, fibroids, and even benign cyst with torsion, hemorrhage, in endometriosis, definitely it will be elevated. The numerous non-gynecological conditions which can cause the peritoneal irritation like tuberculosis, cirrhosis, ascites, hepatitis, pancreatitis, and peritonitis. So you should keep in mind all these things when you discuss or when you counsel a patient with a high CA125 value. So coming to the risk categories, risk analysis methods. So calculation of RMI. RMI is a risk of malignancy index. So RMI is basically a multiplication factor of ultrasound, menopausal status, and CA125. So each has a score. For the premenopausal, it is score of 1, and for postmenopausal, the score becomes 3. Then for the cyst appearance, if it is a multiloculated cyst, solid areas, metastasis, ascites, bilaterality, these are the ultrasound important factors suggestive of malignancy. So if it is no feature, 0, then a single feature, 1, and if more than one feature is there, definitely the score becomes 3. Then next about the CA125. So RMA4 of more than 450 is more sensitive and specific. But the problem with the RMA is that it is mainly dependent on the CA125 value. And we cannot assess the risk of malignancy with this calculation. So that's the fallacy of this particular risk analysis method. So another one is the risk of ovarian malignancy algorithm or the ROMA. So in ROMA, it's a quantitative method where we are incorporating HE4 also. So as I have told you, HE4 is more specific. So as such, the specificity or the credibility of ROMA is more than RA. So meta-analysis has shown that the sensitivity of around 90% and has a specificity of around 91%, since it includes HE4, CA125, and menopausal status again. So you can get this ROMA calculator from the net easily, and there you can assess the category of malignancy. So the calculator itself can give you the calculation of whether it is a case of high risk for malignancy. Next comes the IOTA symbol rules. So IOTA means the International Ovarian Tumor Analysis Group, and that was founded by Timmerman. And this IOTA symbol group, it has a lot of calculations that is basically based on the ultrasound features. So IOTA, they use the symbol descriptors as well as they use the different rules also. If the mass is not recognizable, symbol descriptors cannot be applied, so they more hinge on to IOTA symbol rules. So what are the symbol rules? So here it is divided into benign and malignant forms. So benign, of course, B form, and M for the malignant features. So M1 is irregular solid tumor, M2 is presence of ascites, M3 is at least 4 papillary projections should be there. Then M4 is irregular multilocular solid tumor with the largest diameter more than 100 mm, and M5 with the blood flow, strong blood flow. And B1 is unilocular cyst, B2 is the presence of again solid component where the largest solid component less than 7 millimeters, and B3 presence of acoustic shadows, B4 smooth multilocular tumor with largest diameter less than 100 mm, then no blood flow is B5. So this picture you have to keep in mind, you have to be aware of this picture. So first one is of course the unilocular symbol cyst appearance, and B2 again the symbol cyst with a small solid projection, but it is less than 7 millimeter. Then presence of acoustic shadows you can see in the third one, and fourth one the multiloculated appearance but less than 10 mm, 100 mm. Then the blood flow, of course the blood flow, it is only in the periphery. Then M1 is irregular solid tumors, and M2 presence of ascites, you can see the presence of fluid in the POD and all. Then M3 at least due to more than 4 papillary projections should be there. Then M4 irregular multilocular solid tumors with the largest diameter and all. Then last is the one with increased blood flow. So the simple rules, the risk or calculation or SR risk calculation, that's also available in the net. And it is based on the logical regression analysis model with 10 features. And that there they include the type of oncology center which the patient is under treatment. And so here the risk of malignancy, as you can see in the picture, the risk of malignancy is assessed, and in this particular case it was assessed as around 92.4%. So that includes a lot of features like age of the patient, oncology center, maximum diameter, then solid parts, presence of papillary projection, CA125 values, presence or absence of ascites, presence of metastasis, and all. In IOTA, as I have already told you, the symbol and the malignant features. So IOTA has applied the rule, and according to the rule, rule 1, if one or more M feature is present in the absence of B, definitely malignant. Similarly, rule 2, if one or more B is present in the absence of M feature, it is benign. And if both M are B and M present, or neither B and M is there, then it is inconclusive. So it also has a specificity of around 95% and sensitivity of around 90%. Adenex model is the last one. IOTA Adenex model means assessment of the different neoplasia in the adenexa. So they include the age, oncology center again, then CA125 is optional or not. Then again the maximum diameter of the lesion, then maximum diameter of the largest solid part, more than 10 cyst locules, the number of papillary projections, acoustic shadows present or not, and as presence of ascites or not. So this is a first rank model to differentiate between benign, borderline tumors, stage 1 invasive, stage 2 to 4 invasive tumors, and secondary metastatic tumors. So the advantage of this particular model is it can be handled by anybody, any gynecologist or need not be a trained radiologist. It can be handled by any people, anyone. This uses 9 variables, 3 clinical variables and 9 ultrasound variables. So Adenex model, that particular thing is also available in the IOTA website. Then in Adenex model, it is accepted, according to literature, it is well accepted by the ESGO, all the groups, ISUOG, IOTA and ESG group. Then after entering the variables, the risk analysis can be calculated according to this picture. So it's both in the, we will get the value both in the graphical as well as in the numerical pattern. So it has a cutoff of 10%, and so the sensitivity for malignancy will be around 96.5%, and specificity around 71.3%. So the risk of malignancy when particular case is given, that can be properly assessed by this model. So coming to the role of MRI, most of us might be telling patient to go ahead with MRI. So, but I know that most of the radiologists, also neurologists, everybody is well aware of the MRI picture. They are not simply following the report by the radiologist. They know how to interpret the MRI picture. So we should also have an idea to interpret the MRI. So need not totally depend on the MRI report. So in MRI, that's the right picture. I think that might be clear to you. That first one is for the simple cyst. Second picture shows the hemorrhagic cyst. Third is for the endometrioma. And fourth, the appearance of dermoid. And fifth, round structures shows the neoplastic features in MRI. Train, and you will get you can master in MRI also. Then solid or solid bar cystic enhancing lesions more than 4 centimeters in diameter with papillary projections, irregular thick wall and septa more than 3 millimeters. Then number of septa and the dimensions of vegetations are also very important to detect malignancy in MRI. Then other features like presence of necrosis as well as intratumoral hemorrhage. Then finally, other ancillary criteria like involvement of the pelvic side walls, ascites, lymphadenopathy, etc. So we are all dealing with, most of the cases we are dealing with functional ovarian cyst. So this functional ovarian cyst is part and parcel of the menstrual cycle and usually resolved without much treatment. They develop from the Graafian follicle, and corpus luteal cyst is from the corpus luteum. And sometimes they can produce hemorrhage or they can undergo torsion or rupture into the peritoneal cavity. And most of the times they will be less than 1.5 to 2.5 centimeter. And functional cysts usually resolve over a period of a couple of months. Then these are some of the benign ovarian tumors and conditions. As you can see in the picture, dermoid cyst, it has an origin from all the mesodermal, endodermal and ectodermal component, and usually benign. Then fibromas is the second thing, slowly growing connective tissue tumors, less than 7 centimeters usually. Then cystadenomas, very common. Endometriosis is very common. Then of course PCOS. So what are the complications? Regarding the complications of the cyst rupture and hemorrhage. So in cyst rupture, mostly there will be, if it is clear fluid, there will be clear fluid appearance in the POD and all, and you can check the hepatic area also. Whereas it is a hemorrhage, you can see as an ectopy, you can see the presence of hemoperitonea. So that is another ultrasound criteria to differentiate them. Then ovarian torsion. Ovarian torsion is very important. All ovarian cysts have the potential to twist on their, affect the vascular supply. Cyst more than 6 centimeter definitely needs removal, and chance of torsion will be very high. So nowadays, detorsion is more than enough. There is no risk of thromboembolism. The features will be hyperechoic ovaries. So there will be cystic appearance in the periphery, lack of blood supply, multicystic appearance, etc. will be there in torsion. So let us just have a brief, quick rush up through the management also. Ovarian cyst in adolescents. Usually, if the cyst is 3 to 5 centimeter, repeat scan after 3 months to check for the resolution. If it is 5 to 7 centimeter, offer an ultrasound after 3 months, or you can go ahead with a laparoscopic cystectomy. If it is a hemorrhagic cyst, then you can definitely, it will resolve within 6 to 8 weeks. Emergency surgery in an adolescent is indicated only if there is severe abdominal pain with torsion, or a persistent cyst of 5 to 7 centimeter not resolving in the conservative management, or if you have a suspicion of malignancy. So in a premenopausal ovarian cyst, usually less than 5 centimeter, simple cyst, there is nothing is needed, usually resolve within 3 months. Actually, we are all giving, truly we are all giving OCP. Actually, there is no role for OCP. And if it is 5 to 7 centimeter, yearly ultrasound follow-up is more than enough. But if the cyst is persistent or increasing in size or more than 7 centimeter, definitely you can go ahead with further investigation modalities, or if you can counsel them for a surgery. Postmenopausal lady, a symptomatic, simple, unilocular, unilateral cyst, less than 5 centimeter, low risk of malignancy. You can correlate with the CA-125 also, and repeat evaluation after 4 to 6 months. Even after 1 year, there is no change, you can leave her from follow-up. But if she is symptomatic or any other issues, if you are suspecting a malignancy, definitely go ahead with surgery. So this is a simple algorithm. This is available in the net and all. To conclude, the management should be based on age of the patient, overall clinical picture, symptoms, preferences of the patient, previous surgical history, tumor markers, all the risk assessment. Thank you all for a patient hearing. Let me express my happiness to share my our upcoming project, which will be coming in Venpalavattam, Trivandrum, and expecting the blessings and support from each one of you. Thank you all.
Thank you so much, Dr. Anupama. Now it's time for the discussion. Yeah. So let me invite Dr. Adya Dikshit, Dr. Mayank Jain, and Dr. Ravi Shankar to come to the stage for the discussion.